So in this video, we are going to talk about hypokalemia. Hypokalemia is defined by serum level of less than 3.5 milligram per liter. Patient with hypokalemia can present with different presentations like hypokalemic paralysis, SAER-like presentation, also known as colonic pseudo obstruction. Patient can also present with rhabdomyolysis and arrhythmias. So if a patient came with the hypokalemia, first of all, we see if it is real or whether it is pseudohypokalemia. Which conditions cause pseudohypokalemia? You can see CBC if you find leukocytosis, which can be due to leukemia or delayed processing of sample, can also cause hypokalemia. If these conditions are there, then it is pseudohypokalemia and no further workup required. So if you rule out pseudohypokalemia, it's not there. Then you come to if it is true hypokalemia, then we take proper history, do examination, and basic lab reports. So first of all, uh, if there is a clue or in history or examination of redistribution, uh, what can be the clues? If there is clear evidence of transcellular shift, what condition can cause transcellular shift? It can be due to insulin. For example, we are treating DKA with insulin. We can have a hypokalemia. Beta 2 agonist, familial hypokalemic periodic paralysis, hyperthyroidism, barium intoxication. There are some toxins and drugs that can cause hypokalemia or transcellular shift mechanism. Uh, so toxins and drugs like barium intoxication and two important drugs, theophylline and chloroquine. If any cause is there of transcellular shift, then we treat the cause. If it is severe hypokalemia during treating TK, then we should stop insulin and give potassium supplement. Like this, we treat the cause of transcellular shift. If there is no evidence of transcellular shift, then how we proceed? Uh, there is no transcellular signaling. There is potassium loss going on. It can be lost from renal or GI. So we do the important tests: sport, urine, potassium creatinine ratio, which differentiate between a renal and GI loss of potassium, whether it is renal cause or whether it is GI cause. We can also do 24-hour urine potassium. But due to the time consumed in 24-hour urine potassium, it is impractical, as patient can have severe hypokalemia and need urgent treatment. We cannot wait for 24 hours to get this test done. So if spot urine KCR is more than 13 milliequivalent gram of creatinine, spot urine KCR or 24-hour urine potassium more than 15, more than 15 milligram per liter, then we will say it is due to renal loss. If values are less than this, then we will say it is due to GI loss. In GI loss, it can be due to diarrhea, lipoma, and laxative use. In renal loss, we further inquire about diuretic uses. If there is diuretic use is there in the patient, then it is more likely due to diuretic use, and we stop diuretics and treat accordingly. If it is due to renal loss and there is no diuretic use, then we do further investigations like ABG. If in ABG there is metabolic acidosis, then it is due to renal tubular acidosis. This can be type 1, also called distal, or type 2, which is called proximal. In adult, we usually see distal RT, so we further work up for that and treat accordingly. If in ABG there is metabolic alkalosis, then how we proceed? We see if there is hypertension or not. We see the BP. If it is elevated, there is hypertension. Or if it is normal or low normal. If there is hypertension, then we check the TRAS. renin and aldosterone are done. If there is increased renin and increased aldosterone, then it is called primary hyperaldosteronism. And most common cause is Conn syndrome. It can also be due to bilateral adrenal hyperplasia. So we work up accordingly. If there is raised renin and raised aldosterone, then it is called secondary hyperaldosteronism. And it can be due to various conditions. For example, in renal artery stenosis, there is secondary activation of RAS and renin and aldosterone are increased. If there is decreased renin and decreased aldosterone, then if there is decreased renin and decreased aldosterone, then we do cortisol level. If cortisol levels are normal, then there are it can be due to pseudo hyperaldosteronism. By pseudo hyperaldosteronism, there are feature of hyperaldosteronism like hypertension, hypokalemia, metabolic alkalosis, but renin and aldosterone are low. So, what are the conditions? Uh, there are two important conditions: Liddle syndrome, and one other condition I forgot. If cortisol level are increased, then it is due to Cushing's, and we work for Cushing's. So it is a simplified version of how to approach hypokalemia.